I'm Manoj Karmakar. Welcome to ISSPS TV. If you like any of our videos, do remember to click the like and share button. If you are new to our channel, do remember to subscribe so that you can get regular notification of any future uploads.
All right, so last 2 weeks ago, we presented a talk about anatomy for the lumbar spine relevant for central neural axis blocks. And today we'll be talking about the thoracic spine. And as you have heard from Bernard, it's an extremely different anatomy. We'll do the same approach as we did the last time. So we'll start along the osseous anatomy, and then we'll discuss the ligaments, some of the meninges, the dura, thecal sac, and then the spinal cord. Now, the osseous anatomy in the thoracic spine is different. Taking as your representative vertebra, a typical thoracic vertebra somewhere in the mid-thoracic spine, I'm using the T6 vertebra to start with. Now, note here, you have the tip of a spinous process, but that does not belong to T6. And this again reinforces the fact that in the thoracic spine, like the spines of Godzilla, these are very long spinous processes, and they tend to overlap one another to a very large degree, and more than you would see in the lumbar spine. And therefore, if you look higher up in T1 to T4, your interspinous space is larger. It then comes down to a very small aperture in the mid-thoracic spine from T5 to T8. And then it starts to fan out slightly again from T9 to T12, eventually forming the lumbar spine. Looking back here, the most important thing you must remember is that the transverse processes are angulated posteriorly towards you. In the cervical spine, they tend to be slightly flatter, the same for the lumbar spine. And in the cervical spine, maybe anteriorly as well. But in the thoracic spine, they are angulated posteriorly, which means as you place your probe against the skin, you will be able to see the tip of a spinous process and then two echogenic structures almost at the same level, which represent the tips of the transverse processes. And this is a very important landmark. Adjacent to the transverse process are the ribs. The ribs have two articulations. One, the head articulates with the vertebral body, the costovertebral joint. And as you travel laterally, it then articulates with the transverse process, and it is bound by the costotransverse ligament. So this is the costotransverse joint. Moving slightly more inferiorly now into the upper end plate of T6 vertebral body, the spinous process of T5, we've crossed that. We've now popped under the transverse process, and you can see bits of the lamina. And down here, space potentially filled with ligaments, with vessels, and also nerve roots, approximating the thoracic paravertebral space. So this is an important landmark just below and inferior to the transverse process. This here, of course, is the vertebral body and the thecal sac and the spinal canal. Now, as you come slightly more inferiorly, you're starting to see the spinous process reappear. And together with that, you know that you are now at the level of the facet joints. And together with the facet joints, you start to see the top of the T6 rib appearing right here. Now, this is a useful safety device as well, because then you know that between the transverse process and the next rib, you have the thoracic paravertebral space. And the rib, in some cases, helps as a bony landmark to prevent needle migration inferiorly when you're doing an injection, for example. The facet joints also are angulated anteriorly, and this makes it difficult to approach from an axial direction. When we radiologists try to do a CT-guided injection, we tend to use an axial image, an axial approach, whereas with thoracic, with ultrasound, sometimes we use this plane, the sagittal plane, an inferior to caudal approach. And that may be favored in the thoracic spine. As you move slightly more inferiorly to the inferior end plate of T6, that facet joint is starting to disappear, and then the rib proper continues from here again. Okay. Then from there, we move on to our MRI anatomy. I just want to quickly remind everyone, those who were here last 2 weeks will remember this. How do you differentiate the different sequences on a thoracic spine MRI? The same for lumbar spine. Firstly, go for the fluid signal. So the CSF signal is going to be your guide. T2 weighted images have a hyper intense signal for the CSF space. And this reduces to almost a hypo-intense signal on T1 weighted images. Now, if we want to highlight pathology, remove the fat signal. As you can see from the T2 scan, fat signal in the subcutaneous tissues is almost as bright as CSF space. So we apply an inversion pulse, removing the fat from the subcutaneous tissues. It also removes fat from the vertebral bodies. It suppresses the fat signal and only leaves us with fluid signal around the spinal cord, the CSF around the spinal cord, within the intervertebral discs fluid, and also if there is pathology within the diseased vertebral bodies and the spinous process here. And this is an inversion recovery or a stir sequence. Now, in order to highlight pathology even better, we will administer contrast. It's a heavy metal-based contrast like gadolinium, which is then taken up by the highly vascularized pathological tissues and results in relative enhancement of the abnormal tissues compared with the rest of the vertebral segments. And this is really the only reason why we will want to give contrast in the thoracic spine, or if there is abscesses. So it's abscess and tumors mainly. So once again, T2 weighted, T1 weighted, inversion recovery, and the contrast enhanced scans. Now this is a MRI through the whole spine, and we can now do this quite easily with modern MRI machines. Wanted to show you again the differences in anatomy at the cervical spine, and then as we transition down into the thoracic spine, the mid-thoracic spine, you can see how the interspinous spaces quickly disappear and how much overlap there is between the spinous processes in the mid-thoracic spine. And then they slightly open up again as you approach inferiorly into the lumbar spine. The CSF space around the spinal cord, and as you move laterally outwards, you don't see as much of the epidural space as you do in the lumbar spine. That means there's not as much epidural fat. But if you do see a lot of epidural fat in the thoracic spine, you must immediately think about epidural lipomatosis. As you're moving slightly forward to the lateral side, so you can see that the laminae also overlap substantially in the mid-thoracic spine from T4 to T8. And this gives you a very small working aperture. And now we're starting to approach the facet joints themselves. And you can see the facet joints in the thoracic spine were angulated more anteriorly and therefore not so amenable to access via an axial percutaneous route. But here you see you can still see the facet joints and their classic cranial caudal angulation here. And if you were able to slip a needle through here, you'd land on the articular process and walk your needle into the facet joint. And this is a more favorable approach in the thoracic spine without a curved needle. Moving slightly outwards now, you're starting to see the transverse processes take shape. And then here the neural foramina and their corresponding neurovascular bundles coming out to follow the ribs, which are slightly more anteriorly. And once again, you can see a few dots here within the intercostal space representing the intercostal neurovascular bundle. But once again, as you prepare for your case by reviewing an MRI of the thoracic spine, remember the the axial scans that we perform for you are parallel to the disc, and this may not always be favorable to your planning of your approach, and therefore you must form a mental model in your mind before you perform a block or injection in the thoracic spine. So now this is at T1. We're just going to do a quick scan all the way down on MRI. Now, here's the tip of the spinous process. At the top here, this is going to be just at C7. This is going to be T1 vertebral body. Watch this. As we go down, this is the T1 transverse process, still looking fairly similar to a cervical spine. You can see the T1 rib taking its shape here. And T1 does not have a very nice or well-defined costotransverse articulation. The transverse process here is fairly short at T1. And you have a nice big space here where the neural foramen is. CSF surrounding the thoracic spinal cord. Moving now downwards slightly. 3, 4, 5, 6, 7. I'm just counting aloud just to orientate myself. This is almost at the T1, T2 disc level. And you can start to see that the facet joint is now no longer friendly and angulated anteriorly already. This is at T2, upper T2 level. You can see the transverse process. So the transverse processes are hinged on the upper aspect of the vertebral body. Don't forget. This is a well-defined costotransverse joint. This is at T2 level, costovertebral joint, transverse process, laminar spinous process. And as you come down again, the laminar falls off, as we showed you previously, and you are looking now at the inferior-most tip of the transverse process, and look at this big space here. This is fat-containing tissue. Okay, but beyond that, this is only a few millimeters deep, and beyond that is the black space of the lungs. And this is where we don't want to go beyond. So now here is the so-called the classic thoracic paravertebral space, where below the transverse process, you see the nerve roots and their accompanying neurovascular bundles. And you can see how rich the conglomeration of vessels are around the nerve roots in this area. So you really have to be very careful and gentle as you enter. And if you're performing a procedure to try and hydrodissect a little bit to push away these vessels. Now, one thing on the thoracic spine that you will notice are these black shaded areas on the back of the spinal cord. It's very typical. You will see them on almost every patient that you see. If it's a young patient, they can be even more obvious. These are due to artifacts due to spinal cord pulsation in the thoracic spine. Very pronounced, but as long as they look like these black areas, they should be okay. You go back to the sagittal scan and make sure you don't see any big leash of vessels, because if you see large vessels in that area, then you're looking at a dural or a AVM of the dural space. So you have to be very careful about that. If you just see these dark areas alone, you don't see them on the sagittal, it should be okay. Or otherwise, just call up your friendly radiologist. Now, be careful. Sometimes you get really big vessels accompanying the intercostal nerves, and you can identify one of them here as well. So this area is a bit dangerous because it's very tight. There's not much working space, and there are lots of big vessels in the region. Coming down, this is still upper thoracic spine. We're looking at T3 now, a similar anatomy as T2. Coming down to the facet joint level. The moment you see facet joints, you'll be at the top of the rib already. And once you're at the top of the rib, the other important landmark then, if you're angling along the disc, parallel to the disc, you're starting to get into the intervertebral disc space. So this, sometimes for radiologists, represents a little channel through which we can access the intervertebral disc. It's this space which is relatively devoid, because this is the upper part of the rib. relatively devoid of large vessels. But once you move slightly inferiorly again, you start to see another sliver of tissue coming in. This is already the costotransverse joint again. So very tight working space. This is T4. And coming down, just inferior to the transverse process tip, again, the thoracic paravertebral space with all the vessels in that area. Just about 3 to 5 millimeters below, you're starting to see the top of the rib again. So your angulation needs to be fairly precise. The rib acts a bit as a protection for you if your needle is angulated a bit too inferiorly. So always pull back if you feel the rib. And now this is at T5 level. Now at T5 level, it starts to change just a little bit. Where you used to, let me just show you this at T5 level, the transverse processes are slightly flatter now than they were in the upper part of the thoracic spine. There you can see this is at T4. T5 is coming down a little bit more horizontal and it's starting to spread out a little bit. But again, the anatomy, the principles are the same. Inferior to the transverse process, just here, you're starting to get into the thoracic paravertebral space again. And then one more slice below that is the upper part of the rib. And at that level, the facet joint again. Okay. And now this is going through T6. And you can see sometimes the image will skip because our text will scan parallel to the disc. So don't be thrown off, right? So you have to sort of maintain this mental model in your head. So at this level, similar anatomy again with the ribs, the thoracic paravertebral space, and now coming up to the level of the facet joints again. And once you're at this level, slightly inferior to that, you're at disc level and rib proper already. Scanning downwards again, this is T7, T8. These are this is the mid-thoracic spine level. So there is some space, but because of all the overlap, the amount of clearance that you have from the inferior to the transverse process to the next rib is much less. You can see that in the upper spine, when I was scrolling, we still had 1 or 2 slices from the inferior aspect of the transverse process to the rib. But watch this, in the mid-thoracic spine, once you go below the transverse process of the rib here, the next slice is already, of the vertebral body, the next slice immediately, about 3 millimeters, is the rib already. So that working space sort of cramps down a lot in the mid-thoracic spine. And then now as we slowly approach the inferior part of the thoracic spine, we're coming up to T9, T10 level. You can see liver up here. It starts to then resemble again the lumbar spine. So we're coming downwards now. You can see that once again, the transverse processes are now slightly flattened out and very short. Okay, so this is what Dr. Barnard was talking about. At the lower part of the thoracic spine, this is the cauda equina nerve roots, the filum terminale. So probably this is around L1 level, T12, T11, T10. Now this is where the anatomy changes drastically. From T10, you don't have a nice transverse process like you used to in the upper or the mid thoracic spine. Look at how short and beady these guys are. The costotransverse joint is almost non-existent at this level. And as you go downwards, that very, very short transverse process, they used to be somewhere more lateral, but now they're really medial. So be careful about scanning too lateral because you will then fall off your landmarks in the lower part of the thoracic spine. Down here, just inferior to the transverse process, the facet joint starts to take appearance already. And again, down here, coming down to T11, T12 level, just very, very short transverse processes. And with that, they start to resemble the lumbar spine. Now, once again, just correlating the MRI with the CT anatomy. This is obvious. This is the cervical spine up here. The thoracic spine I've enlarged for you with some labels. But the point again is that the interspinous spaces are larger at the top. They start to cramp down in the mid-thoracic spine together with the interlaminar space, as well as the thoracic paravertebral space itself. And then it starts to flare out a little bit in the lower part of the thoracic spine. Similar for the interlaminar space, you've got a bit more working space down here in the lower thoracic spine. Over here, very crowded. And then as you move upwards again, slightly more space to work with in the upper part. And you can see again, appreciate from this beautiful anatomy of the facet joints and how they are orientated in a craniocaudal direction. A more favorable approach for facet blocks if you are using ultrasound guided injection to go craniocaudal into the facet joints rather than transversely. And just coming out here, you're starting to see the transverse processes all projecting outwards. Here, more facet joints resembling the lumbar spine with very short transverse processes. Now, this is a useful slide to show the principles that we were talking about. This is your patient, the back facing you, spinous process tips visible here, and the ribs and all the paravertebral musculature and how they are orientated. Remember that in the lumbar spine, the nerve roots tend to emerge obliquely and inferiorly along this kind of direction, like a Christmas tree. But in the thoracic spine, they emerge laterally and horizontally. And we have to be very careful about that. Now, we're coming down along the transverse, the spinous processes go slightly more anteriorly beyond that. The tips of the large transverse processes in the mid-thoracic spine. You can see them very nicely here. You don't see them here anymore, partly due to the curvature, but also because the transverse processes are smaller as you approach the inferior part of the thoracic spine. This then is the costotransverse joint over here. And you can see that immediately inferior to the transverse processes, your working space allowing you to access the fatty tissue within the thoracic paravertebral space itself. So identify the costotransverse joint if you can, and that's also another landmark to tell you the most lateral landmark of the TVPS. Scanning again downwards here. Now we are approaching the spinal canal itself. You can see the TVPS over here very clearly. And this is a T1 weighted image. And so you see fatty tissue surrounding the neurovascular structures. And now we're approaching the thoracic spine itself. So and this will give you a small portal of access into the epidural space over here. And then down the spinal cord appearing. So this is a useful way to think about the levels that you are at when you're doing your scan. Just a little image, from one of my procedures in the T8, T9 level. I was asked to do a nucleoplasty at this level. The patient had a little bit of a bulge down here. This here is the spinal canal, right? So, and then the whole gray area here is the thoracic spinal cord. The facet joints, and remember when you're at the facet joints, you should be seeing the rib adjacent to it, and true enough, you do have here. Now, so here's the needle coming in. I placed it first in the TVPS, so I used ultrasound guidance to nip the needle just under the transverse process and hydrodissected a little bit to give me a bit of clearance, and then I inserted the nucleoplasty needle with a curved tip. And here, if you can see around it, this has been washed away, unfortunately. We did the thoracic epidural injection first with a bit of local anesthetic and contrast. So you see these white little patches, so tracking along the posterior aspect of the thecal sac as well. That's confirming that we are in the thoracic epidural space, and that's coming out into the foramen slightly inferiorly. This is an angulated needle, so makes it more steerable. So from here, I know not to go medial anymore. I have to change the direction of the needle a little bit. So from here, I had to change the needle to point it more anteriorly, which is what we did. And as we went anteriorly, at the level of the facets, the ribs, you start to get the thoracic intervertebral disc space. And that's how we entered into the intervertebral disc space in the midline. And that is the RF cannula extending with a clear margin of safety away from the thecal sac. And that's a little bit of our epidural injection that we use to push the spinal cord slightly away from the needle path. So really that's it. I will show you a real life, a real case in a minute. Just wanted to hang up this little tribute slide to Charlie Watts, who was also a blues drummer. And we hope to meet everyone in Hong Kong in the near future. But let me just quickly show you a real case and then we'll walk you through it so you have a better appreciation. Just give me a second here. Okay, I think you should be able to see these two. You should have a sagittal on one side and a axial scan on the other. And this patient has a mid-thoracic vertebral compression fracture, 2-level fracture. And as you're scanning, you try to imagine that you're doing an ultrasound scan for this patient. Because sometimes they get referred pain, so the TVPS blocks can be very good to anesthetize the intercostal tissues. So now we are at the mid level of the fractured vertebra up here. Once again, the classic anatomy, the facet joints, you know to expect the ribs to be at the same level. And once you're up here, you're at the upper lip of the intervertebral space down here. So once you are at this level, then you have access to the intervertebral space should you wish to have that. The facet joints, the ribs. Now, then we are now at the level of the transverse process again of the next adjacent vertebral level, the well-defined costotransverse joint, the costovertebral joint. There's no way to access into this level here. The transverse process again, the rib, and the rib starts to disappear. And now you're on the inferior lip of the transverse process. You can start to see the TVPS appearing, but you can see what has happened because the thoracic vertebral fracture has pushed the margins of the bone, retropulsed the bone a little bit. And that has made a very narrow working portal even more narrow than before. And you can appreciate that this space here is really, really small on this side. And then once again, just 1 or 2 slices below that, you're starting to see the facet joints and the ribs again, and not much space to work with after that. So this really sort of shows you the challenges of doing paravertebral or neural axis blocks in the thoracic spine. Be very careful about how the anatomy changes from upper to lower with the narrowest working portal in the mid-thoracic spine. With that, I would like to stop my sharing. Manoj, back to you.
Thank you, Kenneth, for a wonderful presentation. And I hope, ladies and gentlemen that are logged in here today, you will appreciate that how little we pay attention to the anatomy of the thoracic region, despite the fact that we are the ones that often more frequently place needles, whether it be epidurals or paravertebrals. And I'm also shocked that some folks in the Journal of Most Unpublished Research are often exhibiting their skills in spinal anesthesia in the thoracic region. Now, spinal anesthesia in the thoracic region may have a role, but I think from a safety point of view, given the anatomical illustrations that these two speakers have illustrated, would you be willing to have a spinal anesthesia in the thoracic region? If I were you, I would say no. So why would you do a spinal anesthetic in the thoracic region when you may be able to do an epidural? Anyway, this is a discussion maybe for another day, but thank you, Bernard. Thank you, Kenneth. You really set the ball rolling, and I can tell you, if I were an attendee today, I would say, oh, wow, what a festival it has been, because nowhere you would see discussions of anatomy in so much detail and in so much extensive, expressions, particularly when the two of you have so much knowledge and experience with what we do on a day-to-day basis with our patients.